Thanks for giving me the opportunity today to present our experience with COVID in the Democratic Republic of Congo and in Cameroon. Today I'll present an overview of the epidemiological characteristics of the epidemics and also the characteristics of observed patients. In DRC, the first confirmed COVID case was notified on the 10th of March. The state of emergency was declared shortly afterwards, and barrier measures were implemented, such as closures of schools, travel bans, closures of restaurants, but also the ban of public gatherings. Gombe, which is an area in Kinshasa, was the early epicenter of the epidemic and was confined a month later until the end of June, and it remained the only confined area in DRC. The end of the state emergency in DRC was declared on the 21st of July. Surveillance and control activities mainly included the quarantine and monitoring of travelers, contact tracing of confirmed cases, and later during the epidemic also active research activities. The testing strategy focused on suspected cases, so individuals with symptoms. Screening activities, including asymptomatic individuals, only took place at a very limited scale in Kinshasa. In Cameroon, the first COVID case was declared nearly at the same time as in DRC on the 6th of March. Governmental measures were implemented shortly afterwards on March 18th and reinforced beginning of April. The barrier measures were relaxed again end of April, and schools were opened again beginning of June. Surveillance and control activities were similar compared to DRC, however with more extensive testing of the population. So since May-June, a test and treat strategy has been implemented, including the screening of the population using PCR and rapid diagnostic tests. Comparing the epidemic patterns in the two countries based on national surveillance data. In DRC, on the left side, with a population of over 89 million people, more than 10,200 cases, confirmed cases were notified until beginning of September, including over 330 deaths. The peak of the notifications occurred on June 24th, so around 3.5 months after the first case has been reported, with 197 cases notified on a single day. As a reference, at the peak of the first epidemic wave in France, over 3,000 hospital admissions were reported on a single day. For Cameroon, we had access to the national line list data only from the two most affected regions, Centre and Littoral, here on the right side. Other less affected regions could therefore not be included in the presented analysis. In Centre and Littoral regions, with a population of 8.7 million people, up to the 10th of August, more than 5,400 confirmed and more than 16,400 suspected cases were reported, including around 100 deaths. The notification peak was reached in Cameroon a month earlier than in DRC, on the 22nd of May, so around 2.5 months after the first case has been reported, with 700 confirmed and suspected cases notified on a single day. In DRC, we observe a substantial geographic variation in case reporting. So the vast majority of cases were from Kinshasa, with an attack rate of 0.8 per 1,000 people. This is followed by North Kivu with a 10 times lower attack rate, Congo Central, Haut-Katanga, and South Kivu. In total, cases were so far reported from 18 of the 36 provinces in DRC. It is important to note that the provinces in DRC are at different stages of the epidemic. So while Kinshasa has already passed the epidemic peak, which also drives the pattern observed at the national level, cases are still increasing in North Kivu, for example, and other provinces have more irregular case notification patterns, which may indicate lower surveillance capacities in these regions. In Cameroon, the geographic variation, at least between the two investigated regions, is less pronounced. However, both the confirmed and suspected attack rates are lower in the center than the littoral region, where also case notifications were still higher throughout July and beginning of August. The reproduction number R, which is the average number of infected individuals by a case, can give us an indication of the transmissibility of the pathogen in the population. So as long as R is bigger than 1, case numbers are increasing. Once R is lower than 1, case numbers will be decreasing and the epidemic can be controlled. R can vary during an epidemic due to interventions, behavior changes, or the immunity of the population. And it's therefore important to monitor R over time during an epidemic. For both Kinshasa in DRC and the center region in Cameroon, R never exceeded around 1.6 at any moment during the epidemic. So this compares to reproduction number around 3 in European countries before confinement measures have been implemented. In Kinshasa, R dropped below 1 since June, but has been slightly increasing since August. So this may reflect the relaxation of government measures, so it is important to continue monitoring the tendencies further on. In the center region of Cameroon, R dropped below 1 since mid-May, with an increase observed in June. However, this increase is more likely to reflect changes in surveillance, so when more wider testing of the population has been implemented. Regarding the characteristics of confirmed COVID cases, both in DRC and Cameroon, cases were relatively young, with a median age of 41 and 38 years. So this compares to the first wave in Europe, where hospitalized patients in France, for example, had an average age of around 70 years. Over 60% of cases in both countries were male. Reporting of comorbidities may be incomplete. Nevertheless, in DRC, 25% of confirmed cases reported any comorbidity, and in Cameroon, this proportion was 7.5%. The most prevalent comorbidities were hypertension, cardiac disease, diabetes, and respiratory disease. The case fatality ratio among confirmed cases was 3% in DRC and 1% in Cameroon. In France, for example, to compare among all infected cases, the CFR was estimated at 0.5%. Identification of infected cases in both countries and the follow-up of the final case status, particularly in Cameroon, is likely incomplete, and this makes it difficult to obtain accurate CFR estimates for these two countries. The median age of deceased patients in DRC and Cameroon was around 60 years. So if we compare that to the first epidemic wave in Europe with an average age of about 80 years. Similar to previous reports from other countries, the risk of death also increases with age of patients and with the presence of comorbidities here in DRC. This difference was less pronounced in Cameroon, where also the risk of death started to increase at slightly higher age than in DRC. So in summary, we observed a slower epidemic progression and lower reproduction numbers in DRC and Cameroon compared to European countries. Case notification in the two countries have been overall declining. However, in DRC, there is a strong geographic variation in these tendencies. Cases and deceased patients were of younger age, and the number of reported deaths was relatively low in both countries. Case fatality ratio increased, however, also with age and comorbidities as previously reported. Now, seeing the COVID epidemics unfold in DRC and Cameroon, there are important remaining questions. So, for example, what is the true extent of the epidemic in these two countries? So seroprevalence studies to quantify the number of infected individuals in the population and mortality survey to quantify the actual number of COVID-related deaths can shed further light into that. We also don't really understand the reasons for the different epidemic patterns compared to Europe. So it is unclear whether the lower reproduction number relates to the early implemented control measures, smaller number of superspreader events, or other differences in the environment or behavior of individuals that could result in a lower transmissibility of the pathogen. Investigating COVID transmission within households may be one way to further investigate transmission characteristics of COVID in African settings. And then importantly, a question that remains is what to expect now that the barrier measures have been relaxed. So a better understanding of transmission characteristics and disease severity can help adapting and refining prediction models to the African context. But of course, it's also important that countrywide surveillance and monitoring activities are continuously implemented so that a potential increase in case numbers can be detected in a timely manner. So I would like to thank everyone who has been involved in the COVID response in DRC and Cameroon, particularly the colleagues from the Ministry of Health and the MSF teams present and all other partners who have been actively involved. And thank you very much for your attention.